So looking at HPB cytology and pathology generally, we're going to look at the types of specimens one gets, how we define the different specimens and the nomenclature, talk a little bit about rapid on-site evaluation, because this is has been a bit of a controversial topic, and as you know, it varies a lot around the world as to how often this is used, and then discuss a bit about the preparation methods and the roles of cell blocks and other histological type evaluations, and then just go through what we do in Nottingham as an example protocol. Reporting guidelines, I'll say, if there's time, I'll say a little bit about. Katharina Beerman will be giving more details on the histological or the cytological classifications and problems that we encounter tomorrow. And then a little bit about the ancillary tests and the importance of multidisciplinary team in arriving at a diagnosis and how to manage the patient further. So the sort of specimens we get, a core biopsy, which is a proper defined piece of tissue. We get these from the liver, the pancreas, lymph nodes, and we're very happy when you get those. We may get an ampullary biopsy from an ampullary lesion. Biliary brushings are very commonly taken. We're not talking much about that today, but that's a common thing which we do need to use a cytological approach to. And then sometimes we're lucky enough to get small bits of the bile duct with spyglass biopsy. But today we're talking predominantly about FNA-B, which is from the pancreas, lymph node, or liver. There's a lot of, obviously we talked already a lot about different sorts of needles and FNA needles versus FNA-B needles. But really, from a pathology point of view, there's not much point in categorizing a sample beforehand as being a cytology sample or a histology sample, because in many cases, whatever needle you use, you do get a bit of both. Okay, you get cells floating in fluid, and you get bits of tissue. You can name the procedure according to the type of needle and the gauge of the needle you're using. And one can use a single term really to cover everything, which is FNA, a fine needle aspiration biopsy, which some of it is a bit of aspirate, some of it is a bit of biopsy, or perhaps even better, EUS guided tissue acquisition. Tissue being both cytology and histology. So histological sample can be defined as a macroscopically visible. So you take your needle, you get a bit of tissue sample from it, and you can actually see a little bit of a fragment. Okay, it might be a nice long fragment or just a little bit of tissue, which you can actually see. A clot is an amorphous, essentially is a blood clot, is an amorphous or needle-shaped coagulum. So it might be blood that actually clots in the tube and actually just becomes like an amorphous thing, or something which actually clots in the needle. We'll come to the importance of clots in a minute, because really a lot of tissue can be hiding in that. And then a cytological sample, just a fluid sample, pure fluid sample, which contains cells derived from the lesion. So as I say, core biopsies we really do like. You can see if we can get a nice sample like that, then we usually don't have too much problem in making a diagnosis, assuming it actually has come from the lesion that you're trying to get. And you can see that you've got a nice tissue architecture with glands in the stroma. You've even got a nice lymph nerve over there with some tumor possibly around the nerve over there. And that makes it very easy for us because we can see the invasion very nicely. This is what we get more commonly. So we'll get a clot, which is clotted either in the needle or subsequently in the tube, which may look like it's just blood, but actually when one examines it, if the sample has been taken nicely, you can see that within that there is actually a lot of... what's happened there? Don't know why I didn't like my slide, but you can see there's actually a lot of tissue hiding in there, and that is really the gold that we're after amongst all the dross. So how can we prepare these samples? Well, you can do a direct smear, which may be, as mentioned, which may be air-dried or wet-fixed. Fluid samples can be taken either into a cell media fluid or into alcohol-based fixatives, which are used generally in most cytology sort of samples, or even directly into formalin. And then once you've got that fluid sample, you can use a liquid-based cytology using one of the things which have been designed really for cervical cytology, ThinPrep or SurePath, which work pretty well. Or if you don't have that sort of machine available, you can easily make a Cytospin, which is a somewhat of a more low-tech machine, but which works very well for this purpose. And then one can also make cell blocks in order to get some sort of histological sample. Having said that, as I'll show in a minute, probably the best way to get a histological sample is to actually sieve out the solid material. And then we'll talk a little bit about rapid on-site evaluation. So smear preparation, this obviously may be done by a cytotechnologist or a pathologist or a clinician, and the material is put into the slide and then smeared out. And obviously you get quite a range of what the cells look like. These have been stained with Giemsa as a air-dried material, and these are spray-fixed or maybe fixed but the cells are often quite obscured in the blood, which is inevitably present in these samples, and also depends a lot on how well you prepare the sample. Whereas this is a ThinPrep slide, the similar thing you'd get with a Cytospin, you tend to get a more evenly distributed set of cells which are less obscured by other material and therefore easier to interpret. So if you send the sample to the lab in some sort of fluid, this is probably a Cytorich Red, which is a methanol-based material. The cells that is then spun down, and a Cytospin can be made using these techniques. So what do the guidelines say about how one should do it? Well, there's actually very scanty information about how people say one should actually prepare these samples. Papillary Society's got very little about tissue preparation, although it's got a lot about interpretation of samples. The Royal College of Pathology in the UK produced guidelines which even in 2010 seemed to be out of date as soon as they were made. And certainly I've done a survey in the UK as to how people are doing it, and there is a big variation in how people prepare samples in the UK, and I think that goes right around the world. And if you look at the studies which have been done, similar to with needles, there are many small studies, many of them are retrospective, and a lot of them are very obvious biases. And there's particularly, if you look at the meta-analyses of rapid on-site evaluation versus non-rapid on-site evaluation, most of these were uncontrolled case series. One meta-analysis did find an advantage to Rose with increasing sensitivity, but another found no advantage. These two studies in 2015 were two randomized controlled trials, which is fairly rare in this area. I think we've already discussed this already. So you could have fewer passes with rapid on-site evaluation, but the sensitivity and specificity and accuracy were very much the same, as was the cost. And we already have seen that recent studies have shown that 3 to 4 passes are generally sufficient anyway, whether or not you use Rose. And because of that, the ESG in the guidelines didn't really make a recommendation on the use of Rose. You could, or you can, or you may not use it, depending on what your centre likes to do. This is just a summary of the different needles. Again, you've seen this already. Just showing that with the FNAB type needles, Procords particularly, with around the second or third pass, you've already reached a very high, very good sensitivity. With the FNA needles, around the fourth pass, you start reaching your sort of 90% sensitivity in many studies. So again, we've been through this in a previous talk. So 3 to 4 needle passes with an FNA needle are generally sufficient, and 2 to 3 passes with an FNAP needle. So looking at the evidence for preparation, again, many studies, but very difficult to compare. Many are retrospective, and you can either do it by you splitting the sample and using some of the sample for one method and part of the sample for another, or use different patients. Some of the patients getting one method and other patients getting another method, or you do different passes for different on the same patient. So each of those ways have got different problems associated with them, which make comparison not 100% correct. But if you look at the evidence for direct spear versus a cytospin, so this is there seems to be mixed results, and it probably to do with the bias of the people doing the studies. Cytospin versus making a cell block, again, best with both. Now, cell blocks, or at least some form of tissue for histological sample, is really of great use for us, because we can do a lot of things with it. And if you look at the studies for sensitivity, most show very good sensitivity using cell blocks, generally when used in addition to cytology. If you do a direct comparison with doing one or the other, the cell blocks do seem superior. But obviously with cell blocks you have the advantage of preserving the tissue for further work. We've already, Peter already mentioned the importance nowadays of often in using immunohistochemistry and various other tests for which may become very important. There are a lot of different cell block methodologies. You can use agar, plasma thrombin, Cellular-Baz, Shandon, but essentially, in your own laboratory, it doesn't really matter as long as you use a technique which actually does work. So, in summary, ROSE may be used if there's local expertise in use, and staff are available to prepare the samples and give a decent answer, but it does consume material. And therefore, if you are going to use ROSE, always take additional material which should be used to make some sort of, to have some sort of sample for histological or further testing available. If ROSE is not in use locally, then the sample should just be submitted in fixative, which may be an alcohol-based fixative or even in some centres formalin. Now, solid material. If you get solid material, these should be removed by filtration through a Casseton process in a paraffin block. And if you get that, you may not need to make a cell block. It's a much easier way to do it. Remaining fluid should be spun down. Pellet can be then used to prepare a cell block, or just do your cytology preparation if you've already removed some solid material with your by filtration. So the guidelines do suggest that evaluation of tissue obtained by EOS-guided sampling should always include some sort of histologic preparation, whether it be cell blocks or formalin fixed and paraffin embedded tissue fragments, which have been got from the specimen, and should not be limited just to smear cytology. So, again, there's not a lot of evidence to support this, but it's pretty self-evident, really, if you think about it. If you want to be having tissue available to get everything you can out of the sample. So this is one form cell block with agar and thrombin, and you can see that this material is put in to make a clot, and your fragments, which otherwise would be on your cytology slide, get coagulated into a clot. So going ahead and just going through what we do in Nottingham, the sample is put in, by the endoscopist directly into a cytology fixative. We use Cytorich Red, but it could be anything really. If they see an obvious tissue core, they'll take that out. So on occasions when they actually see something, they'll take that out and submit that separately in formalin. But most of the time, we just get it directly in a cyto-rich red vial. In the lab, the sample is filtered through a microcassette, and solid material, which is got from that, is then processed as a histological sample. The remaining fluid is spun down, and we make 2 cytospin slides, which are pap stained for cytological evaluation. And with solid lesions, we almost always get solid material, which we use for a cell block. But if we don't, we can then make a cytoblock from the pellet over there using a thrombin clot. Just to show you what happens in the laboratory, it's done in a FUMID, because obviously it's all fresh material. This is Mark Jr., one of the biomedical scientists in our laboratory, preparing it. I can promise you he was actually looking at the sample while he was doing it. He just turned around to smile for the camera. So this is what we use for to actually filter the material. So this is a cell-safe biopsy cassette. And you can see that he's pouring the sample through one of those. So anything which is, and the rest goes out into a Petri dish. Obviously, these are all single-use equipment. It doesn't look like there's very much in there in the sample, but that will get processed. And you quite often get a surprise, and you get even tiny little groups and fragments, which in some cases, even in cystic lesions, you sometimes get some really important stuff in there. And then obviously this is a case where there actually is a clot, in which case you'll pipette it with a disposable pipette through the cell safe, and all the clot is retained in there. And when you get that sort of thing, you really don't need to make a cell block. That becomes your histological sample, or your sample with gets processed by histological methods. The rest of the sample gets put back into a tube and gets spun down. You can see you've got a nice pellet over there, and then gets put into one of these contraptions. Again, this gets spun down, and a slide is made. If a cell block is required, the pellet gets put into there together with your stuff which coagulates it, and again that gets spun down. So using this methodology, in the vast majority of cases, we do get material which we can do, which we can get a diagnosis on, looking at material in the clot, as well as getting samples that we can examine in a more conventional cytological way. And you'll see most of the pathologists in our lab, when they get the sample given to them, you'll be given it all together. So you'll get your clot and you'll get your cytology sample. Most of us will go straight for the clot and have a look at it. And if you see tumor in that and you've got a diagnosis, you don't even need to bother with a cytology sample, because generally histology is easier than cytology. So looking at the reporting guidelines, I'm not going to say too much about this because I think it will be discussed later. The most established system that is used, and it's used pretty much throughout the UK and I think in many places in Europe as well, is a 5-tier system with C1 to C5, with your malignancy in C5 and insufficient C1, benign C2. These two are a bit of a problematic area because there's a variation in how pathologists use the C3 and C4 categories, because it's not really defined as to what degree of atypia and what degree of suspicion you need to put into either atypical or suspicious. The other problem is that for tumours such as cystic tumours, very difficult to know which category to actually put them into, because you don't often know pathologically how they're going to behave. And neuroendocrine tumours as well that don't really lend themselves to this to this schema, because we can't really gauge how they're going to behave, whether they're going to be behaving in a benign or malignant way. So in those cases, we'll usually just give our diagnosis rather than actually give a category. The PAP Society guidelines, which came out a few years ago, are similar, but they actually make it into 6 categories. So they've got the additional category of this neoplastic, which includes cystic lesions, and the neoplastics could be benign, like a serous cystadenoma, could be things which are of undetermined malignancy, such as an IPMN, or well-differentiated tumours, such as well-differentiated neuroendocrine tumours and solid cystic papillary neoplasms, which can behave in a malignant way as well. I don't think these have caught on very well in Europe. I'm not sure. I don't think there are many centres which are using these. The problem that we have with them is that by going from 5 categories to 6 categories, it kind of could cause confusion. But they do have some inherent advantages. So just looking at the categories, the non-diagnostic category may be non-diagnostic for a variety of reasons. You may get no you may get no cells at all. You may only get blood. You may get a lot of artifact present where your blood is obscuring the cells, and that would be particularly when using smears. You may get material which has been picked up along the way from the stomach or the duodenum, and you may not even be sure, particularly if it's a cystic lesion, whether it's come from the cyst or whether it's come from the lumen of the gut. You might just get normal acinar and ductal material, and you may then not be sure whether if there is a lesion, whether it has actually been sampled or not, or whether it is just a benign. Whether it is just benign material. And if one gets non-specific cyst contents, such as histiocytes, etc., one can really just say it's a cyst, but you can't really go any further than that. The negative for malignancy category, where there's no evidence of malignancy, but you've got features which actually do explain the abnormality which has been seen. So you may get reactive ductal or acinar epithelium, together with inflammation, some necrotic debris perhaps, and features consistent with chronic pancreatitis. One has to be careful in this sort of with this sort of thing, though, and there always is a caveat, because quite often malignant tumours, cancer of the pancreas, does coexist with pancreatitis, with chronic pancreatitis. So the fact that you're getting some features of chronic pancreatitis in your aspirate doesn't mean that there isn't also a cancer present somewhere there as well. So one has to just always keep somewhat of an open mind with that. If you see cyst fluid with yellow pigment and some inflammation and histiocytes, that is likely to be a pseudocyst, and particularly if you add in the other diagnostic modalities you've got, such as fluid amylase and CEA, then you can make a fairly positive diagnosis. And in fact, the Papa Nicholas Society do recommend that when you come into making your final report, you should actually take into all these other things into account. So the radiological appearance and all the cyst fluid biochemistry, because obviously then you're going to reach a more defined, a more definite diagnosis. And these are some examples of benign ductal cells, and there's some benign acinar cells. These showing a somewhat more reactive appearance. This showing a lot more reactive appearance. These you might even start worrying about atypia, but the cells, because there is a little bit of crowding, but the nuclei are fairly regular, and you've got nicely defined nuclear membranes. And you sometimes see this sort of appearance where you get inflammatory cells, and you get these sort of globules, hyaline globules, which may be indicative of coming from a calcific pancreatitis. And this is a clot of one of these showing similar things. So you've got some reactive epithelium there, and some of these sort of hyaline sort of globules, which are probably from a chronic pancreatitis. And this is just showing some histiocytes and inflammatory cells from a cyst. the typical category is a heterogeneous category, and where you've got changes which are more worrying than just reactive changes, but not enough to actually call it suspicious of malignancy. It may be that you've got the sample is limited because of preparation artifact, or there's some crushing of the cells, or there's a lot of background inflammation with only very scanty atypical cells. So this is really where the pathologist is sitting on the fence and saying, we're really not sure, we don't know. Just an example of a fragment which could be from a reactive benign condition, but is somewhat atypical anyway. The neoplastic category includes all your cystic lesions, serous cystadenomas, and nowadays with if one has a clot or some sort of tissue, it is much easier than it used to be to make a diagnosis of a serous cystadenoma, because the cells themselves are fairly nondescript, but with the immunohistochemistry with inhibin, it's so specific and sensitive that even with very limited material, one can actually make a fairly good diagnosis of a serous cystadenoma nowadays. Neuroendocrine tumors are usually fairly easy to diagnose, and your IPMNs and MCNs, as you said before, one advocates using all the diagnostic information that you have before actually producing a report. So what does the cyst fluid macro look like? Was it stringy, sort of tenacious mucin? Obviously the microscopic features, and then what is the CEA level, what's the amylase? And if you've got access to the molecular tests, there are, the molecular tests nowadays are fairly accurate in helping make a diagnosis of a IPMN and mucinocystic neoplasm, but I don't think many centres have this, and we certainly don't at the moment. And I'm not going to go through all that. Just to mention, the suspicious category, there are four major problems about diagnosing pancreatic cancer. Firstly, it may be very well differentiated, and the cytological abnormalities may be very subtle, and that makes it therefore difficult to come to a definite diagnosis. That's simply how we're just not quite good enough to actually put our heads on the block and say this is definitely cancer. So you might have a very good sample, but it's just the lesion itself combined with our own biases which make us unable to make a definite diagnosis. In some cases, there's very scanty cellularity, and as we mentioned, some pancreatic cancers have got a lot of fibroblastic response, and the tumor cells are only a small proportion of the actual neoplasm, and in those cases, you just don't get enough cells to actually be absolutely convinced that it is cancer. You can get reactive changes which mimic cancer, and particularly in autoimmune pancreatitis, pathologists have been caught out in this sort of sample, so one has to be careful in that sort of context. And then occasionally you can get GI contamination from the lumen, which can also be atypical. So the majority of our suspicious diagnoses will turn out to be malignant. So there's a high positive predictive value, but there is always a possibility that that one of these other things has crept in. And positive includes adenocarcinoma and all the other sorts of malignancies. As mentioned, if you get tissue in a clot or other sort of tissue, one can then start making more specific diagnoses such as lymphoma and high-grade neuroendocrine cancer. The diagnostic pitfalls in brushings, particularly more than in FNA, primary sclerosing cholangitis often gives you very atypical appearance. If the patient's been stented, one needs to know about that because that can give you a lot of atypia in its own right. atypical squamous metaplasia can look very, very frightening. And in fine needle aspiration biopsy, as I mentioned, autoimmune pancreatitis is a classical cause of overdiagnosis. So I think the important thing for you to know for this is that we're pretty good. Specificity is high. I think 90% would be considered a low specificity for positive diagnosis. So one aims to get sort of close to 100%, but it's not the same as getting a nice core of tissue cytology. So the important thing that, from a pathologist's point of view, is that clinicians, and particularly patients, are aware that it's not the same. A cytological diagnosis of cancer is not quite the same as a histological diagnosis of cancer. It's not perfect. Sensitivity in brushings is relatively poor, so 50 to 60% you can expect to get in good hands, and obviously much better in fine needle aspiration. I think I'll leave it at that.